Welcome to today's CE presentation brought to you by the Nestle Nutrition Institute, where our vision is to bring nutrition to life for the people who live it. Financial support for this presentation was provided by Nestle Health Science. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented and is for educational purposes only and is not intended as a substitute for medical advice. Without further ado, it's time for our moderator to take it from here. Sit back, relax, and enjoy the presentation.
Welcome, everyone. My name is Yvette Gaughan. I'm a medical affairs manager with Nestle Health Science, and I will be the moderator for today's program, Managing Today's Tube-Fed Patient from Hospital to Home, Lessons Learned and Myths Busted. I am thrilled to introduce today's speaker, Cynthia Reddick. Cynthia is a home tube feeding expert, educator, and strategist, having worked in home care for 23 years, passionately facilitating patients' successful transition from hospital to home on tube feeding. She works to promote positive clinical outcomes, and she believes a patient's positive relationship with their feeding and their feeding tube impacts compliance and quality of life. She developed her passion for nutrition support interning at the City of Hope National Medical Center in Southern California. She enjoys presenting roundtables, clinical posters, webinars, and case studies in the area of home care tube feeding. And she's also been a guest speaker for the Oli Foundation, for NHIA, for Aspen, and the Academy of Nutrition and Dietetics. And that includes a variety of topics related to home tube feeding. So it is my pleasure to turn it over to Miss Cynthia Reddick. Take it away.
Thank you so much for that terrific introduction, Yvette, and I am so excited to be here with you all today. Before I get started, I want to share my relevant financial relationships are with Nestle Health Science as a member of their Speakers Bureau and Medtrition as a member of their Clinical Advisory Board. And my relevant non-financial relationships include working on the Oli New Connector Working Group, as well as acting as a member on the GEDSA Clinical Advisory Board. So this is my favorite subject to talk about, home tube feeding. Buckle up, we have a lot of ground to cover. So my objectives are listed here for you, and get in closer to your computer. If you're sort of across the room, I've got some interactive things I'm going to do with you. I want to learn from you a little bit as we get rolling here. But before we start, I want to cover what we're going to talk about today. I'm going to talk about home tube feeding and what are the key considerations for you to keep in mind as you're preparing to discharge a patient from the hospital to the home care or subacute setting. And explain appropriate types of documentation that is required to help successfully set a patient up at home. We'll talk about different considerations for commercially prepared formulas, including, I'm going to touch on plant-based, blenderized, organic options, because that's quite a bit of a hot topic these days. And then I want to share, and identify potential challenges as we're moving through, literally in this moment, moving through this ENFIT conversion in the acute care setting as well as the home care setting. But before I start, I'm making an assumption here. I think I'm probably right that there's a lot of dietitians tuning in today. And I want to pass along some advice that I was given when I was brand new. I wasn't even a dietitian yet. I was working to get into my internship, and I gave up my high-paying waitressing job as I was in college to go work for a tiny little hospital in Glendora, California as a diet tech to get that hospital experience. There was a dietitian there. She wasn't even full-time. It wasn't big enough to employ a full-time dietitian, and we would cross paths from time to time, and she said something to me that has stuck with me, and I pass it along anytime I get the chance, because it was just one of those random encounters. She has no idea what she did for me, and I hope to be able to pass it along. I know what this sort of advice can do for other people. And that is to get good at things that other people are afraid of. And this was before I even became a dietitian. So it set my mindset before I even started that journey in nutrition support to get good at nutrition support. And that led me to getting my CNSC. It led me into this world of home care, which at the time in 1999, it was a bit of this uncharted territory in the Wild West. So my goal today, by the time we're done with all of this content that I just talked about that we're going to cover, as well as a little case study to get you thinking the way I think, and you know, with some interactive polls that I've got for you, you know, by the time we're done, I hope that you feel a little more empowered to step into this realm of understanding more about what happens after patients are discharged home on tube feeding. So on that note, I've got a polling question because I want to know my audience. I want to know what you want to know. And so our poll has a set amount of questions. It looks like it's open now. So I really want to understand from you, from your perspective, what is the most challenging part of working with home enteral nutrition or preparing a patient for that discharge into the home enteral nutrition space? So is it formula selection? Is it managing the tolerance issues that come with that? Is it, you know, what do I educate these patients on? Is compliance your most challenging, the patient compliance the most challenging part? Or navigating and managing, you know, this realm of insurance, which we don't get a lot of education about when we're new in our career. So let me take a look at how we're doing here. I think we've probably got a few more seconds before you make your selections. Here we go. Okay. So it looks like the majority of people, it's kind of almost a three-way tie here. So tolerance issues are a big deal for you. Insurance is a big deal for you. Compliance on that home care regimen, and then patient education. So good news, we're going to cover all these things. All right, perfect. So let's go ahead and move on. That was excellent. It helps me understand that you're in the right place, and so am I. All right, so let's get started. So what drives decisions in designing a home tube feeding regimen? So these are all important things that play into the decision making as we're preparing that home care plan. So we want to optimize compliance, you know, when they don't have 24-hour nursing, supervising the administration and things, you know, it's on the patient and their caregivers to really make that happen. And insurance coverage plays a big role because if it's not financially achievable for a patient, they're less likely to be compliant, and we know that. We also know that quality of life, you know, once they leave the hospital doors, that world of this controlled environment changes, and they get to go home and sort of meld it into their lifestyle, especially if they're a long-term tube feeding consumer. And then a home care formulary can also play a role in the design of that home tube feeding regimen, because sometimes certain things are available at home that maybe weren't in the hospital, and vice versa. So I was thinking about, how do I want to convey in an hour over 20 years of experience in home care in the most effective way? And I thought I would go through this in a side-by-side, so to speak. So what does tube feeding look like in the hospital compared to what does it look like at home, and how can it change? And I think that, you know, when you're in the hospital, I want you thinking about that as you're preparing your patient for discharge, right? When the patient's in the hospital, you do what you need to do to optimize their stay in the hospital and get them discharged. But as you edge closer and closer to that discharge, these are the things that you need to think about and start asking some questions about how might this look different for your patient at the home. So I hope to pull the curtain back and provide a little insight in just a little bit of time. And then at the end of my presentation, we're going to have some time for Q&A. So keep that in mind. So stay close. Don't go too far away. So we're going to cover all of these in the next dozen or so slides, one by one. We're going to talk about method of administration, formula selection, supply options, feeding schedules, pump type, feeding system, and what does it look like in the hospital compared to it at home. So let's start with method of administration, pump feeding. So most every hospital regimen is standardized for pump feeding. Most every patient in the hospital is pump fed. It's a way to control variables. It's a way to reduce risk of intolerance. and it standardizes things for nursing. But when patients come home, we don't have 24-hour nursing. We have to think about, what the patient is going to be having to do, or their caregivers, as it relates to that pump feeding. So we know that pumps can feel a little more medical. It can feel sort of high tech for some of our populations, and it gives patients less time, in between the feeds as well. So these are things for us to think about as we're choosing that pump feeding regimen. So gravity feeding, this is like a commercial for gravity for home care, because we don't use it much in the hospital setting, right? It's not typically part of the standard of care in the hospital sometimes, but it's the exception. And it lacks the automated infusion that a pump provides. It lacks the ability to record that volume delivered. And it does require more nursing contact hours, where with a pump, you can sort of set it up and automate it to do all these things, but a gravity feeding is like a bolus feeding, is going to require some more nursing contact. But in the home care perspective, when you look at it through our, home care lens, it's an excellent transition method between the hospital feeding, so between a pump and bolus. We recognize that in 2.8 days, you can't necessarily trial a patient on gravity or bolus feedings in time for discharge. So if the patient's on a pump in the hospital, but you want to send them home on bolus, but you're not feeling really good about that idea, gravity is a lovely option. And gravity feeds, like the picture shows, comes with equipment, right? So it comes with a pole, and it comes with a gravity bag that allows you, with a roller clamp, to simulate a pump feed. So you can set that gravity feed up to infuse very slowly and mimic a pump, but it doesn't give you the precision of a pump. But think about it as a transition to bolus for your patient who you really don't see a reason to keep on pump, other than you haven't had a chance to really trial them on bolus. It's also less expensive. So when we do have patients that are self-paying, it's less expensive than pump feeding. So bolus feeding, which I talked about, so gravity and bolus in home care is different, right? So you have to think, and I'm very fussy about language in home care and with orders. Gravity, when you write an order for gravity feeds, it implies certain supplies that I showed you on the prior slide. When you write an order for bolus feeding, it implies certain supplies, like you see on this slide. So it just is a syringe and the formula. We don't see it a ton in acute care, more in nursing homes, but it lacks that automated infusion. There's more nursing contact hours needed, and patients who are sicker, higher acuity, they're probably going to have more tolerance issues with bolus, and that's why we don't see it as much in the hospital setting. But at home, it allows patients freedom, mobility. They can mimic meal times. They're portable. If they have a share of cost or have to self-pay for the method, then it's a less expensive feeding method. But it does allow for more rapid feeds, and so that can be good, and that can be sometimes bad if they're power feeders, if they're feeding too fast. Okay, so we talked about pump, we talked about gravity, we talked about bolus, and now I want to talk about an innovation. This is a new feeding method. It's been available for us in home care for a couple of years now, and it's a fantastic option for patients who don't need a pump, who are gravity fed, who are able to be fed in the stomach with either blended formulas or commercially prepared standard formulas. All work in this feeding system. And the way it works is you can put formula inside this bag. This is called a Boley bag. And then you connect this large cap link to the bag of formula. And then this is the little connector that connects to a patient's feeding tube. And so it's an ENFit design. So it's designed for ENFit device users or patients with ENFit tubes. Otherwise, you would need an adapter for that. And it allows a patient to squeeze in a thicker formulation if they're home blending or they're using a commercially prepared blend. But it, like I said, it also works really well for standard formulas. And it allows a patient to have a little bit more control over how they move about the world with their tube feeding. It also provides an opportunity for patients who are bolus fed, or excuse me, patients who are gastrically fed and who can tolerate actual real food. You can connect this small cap link to pureed vegetables, pureed fruit, yogurt, things that come packaged in these little squeeze packs are compatible with the small cap link, and you can actually walk into a grocery store with, for example, mom and dad go into the store with their family. One child is a tube feeder and the other is not. They all get to walk into the store together, pick out a snack, and it sort of normalizes that experience. So I think that's a fantastic option. And then there's another option that's just recently launched. This is called a decap link, this Dream Cap packaging, which is the Tetra Prism packaging is compatible with this decap link, and you can actually allow bolus feeding directly from a carton of formula. This happens to be a carton of water, so you can use water as well, and it connects directly to the patient's ENFit feeding tube. So again, it's designed for gastrically fed patients. It's designed for patients that have a tolerance of a bolus style feeding because you have a limited control of the rate. Another drawback might be that there are prescribers out there that don't know it's an option. It is not indicated for jejunal feeds, and availability, you may or may not have availability through your home infusion or DME provider, so that's something to talk to your home care provider about to find out if it's available to you and if it's appropriate for your patients. Okay, moving on. So we've talked about method of administration. Now we're going to talk about formula selection. And I can say that the difference between the hospital and home care is really driven by availability, right? So hospitals have a set limit of options, but when a patient goes home, all of those options sort of open up, formulary dependent, right? So when a patient's in the acute care stay, formula selection, we don't have to really critically think about it in a financial way. You get to choose the appropriate clinical option for your patient, and that's what should happen. There's certain protocols, especially when they're, in an ICU stay and making their way through the hospital towards discharge. Follow your hospital protocols for your formula options, but then as you are moving towards discharge, start thinking about what might be a better option for your patient after they leave the building, right? So there could be an option to change a patient to a 1.5 formulation at the home setting when that wasn't available in the hospital setting. So I've had that experience with hospitals that had to blend a 1 cal and a 2 cal to get a 1.5 mixture. But when a patient comes home, that's not a great feeding regimen. So moving them to a 1.5 with fiber, without fiber, whatever those options are. But do you know that in home care, insurance coverage can sometimes drive those clinical decisions that we're making about formula selection? So I talked about 1.5. That is the most commonly used caloric density formula that we use in home care in the adult population. I can say that the plant-based, organic, and blended options are more available in the home care setting. In fact, that's sort of where it started, and it's moving up into the acute care space. So we have a lot of other options for patients who have tolerance issues, who have lifestyle or vegan lifestyle preferences that way, allergies, things of that nature. So we get to use those options in home care more regularly than maybe most hospitals do. And also, home blenderized foods may be incorporated into the patient regimen. So think about that, be open to that as a clinician, educate yourself about what good options are for your patients. It's very common. Like since I started in home care, I was going into patients' homes back in 1999, and they have been putting porridge and prunes and applesauce and different things through feeding tubes for as long as there's been feeding tubes. So it's not something new for them. We're just talking about it more, and it's sort of becoming more normalized. So keep that in mind as well. And then the other difference in the NICU space or in the infant space is that we use liquid or ready-to-feed formulations inpatient, but when patients come home, we switch them over to powdered and reconstituted formulas. Okay, so we're going to take a little diversion for a moment because I want to talk a little bit about some research that I did with a home care population that gave me a little more insight into the plant-based consumers, right? So we know that plant-based formula options are growing, but there's still a little bit of confusion about what's plant-based, what's blenderized, organic, non-organic, right? Because they all kind of get mushed together. But there is a difference, and I think it's really important for you to understand the different categories of the plant-based options. And so this research that I shared with my colleagues back at the Aspen conference in March is shown here. So what you can see is, and what's not on this slide, is that 14% of the total home enteral nutrition population on service was using plant-based formulations. So of that 14%, 32% were using an adult standard plant-based option. And then the next largest group was 28% were in this blenderized category. So what you see here are what we call HCPCS codes. So this B4150 is a billing code. It's how we categorize formulas in home care from a billing perspective, insurance coverage perspective. So the standard formulation B4150 is our biggest player in the home care space. And then B4149 is our second runner-up. And that's the blended category. And most of these patients are made up of our under 18 population, which I'll show you a little bit more in detail here in a minute. So then we go down to peptides. So we've got intact protein, standard, intact protein, blenderized, and then we go into the adult peptide space. That's the next largest grouping of patients. So there's adult peptide B4153 plant-based options, and then there's a pediatric. So this B4160 category is our pediatric polymeric, or that pediatric standard formula. And then our smallest group is this B4161, which is the pediatric peptide. All right, so moving into a little bit more detail, which this breaks down, I think this is where it gets kind of nitty gritty and sort of interesting. I like to peel it back a little deeper and deeper. So in that population of patients that we studied, we saw that 39% of this blended category was under the age of 18. So remember, I talked about that. So it's not the majority in terms of adult versus pediatric, but in terms of age grouping, it's the largest user category. So 39% of our pediatric patients using plant-based formulas are using a plant-based blend. And then it goes down from there. The next largest group would be that standard intact protein pediatric formulation. So what we call pediatric polymeric. So that's the next largest group of plant-based users. And then as we go into the adult grouping, so this 18 to 35, if you were to kind of add them up all together, you can see that the majority of those patients are tolerating standard formulas, which is no surprise to us. So this is our largest grouping of plant-based users in the adult space. And then it goes down into the peptide or the intolerance, right? So we're not going to see any numbers here because these are pediatric formulas. But in this B4153, that's sort of the next grouping of patients size-wise in that plant-based space. Okay, so thanks for letting me take you on that little journey for a moment. So we've covered method of administration, we've covered formula, we're going to talk about supply now. So the supplies that go with tube feeding can be dictated by the hospital formulary in the hospital. They're usually a little more fancy, sort of expensive options in the hospital, and there are formularies from the purchasing agents within that hospital that drive what options are available in the hospital, same way that we do for the formula in the hospital. So things like adapters, extension sets, the way that we secure tubes, what we call tube securement devices, dressings, things of that nature. We're very much used to seeing pump sets when our pump-fed patients have a feed and flush option in the hospital. And then we're having to navigate in the hospital whether a patient has ENFit or what we call legacy tubes. But in home care, what I hope you walk away understanding and advocating for your patients is to help them understand that when a patient goes home, they're going to get what they need, but it might look a little different. In fact, it most likely will look a little bit different. We try to provide what we call home care friendly options, right? So home care friendly is a term that I use all the time because it means a lot of different things. It means easier to use, like more user friendly, like non-clinical user-friendly options. And in many cases, it allows us to provide some duplication or redundancy in some of these options. And in many cases, what we're able to find for home care can be cheaper than maybe what was being used in the hospital. So when it's less expensive for us, it allows us to provide more offerings for our patients in the home setting. So we're looking for something that's financially achievable for us, but clinically appropriate for the patient. So the brands may be dictated by that home infusion or DME company's formulary. Putting a little plug in here for this feed and flush feeding system, common in the hospital, not the standard of care in the home setting. So we work with manual flushes, preparing your patient to understand that the feed and flush system is likely not what they're going to receive at home. That will teach them how to manually flush their own tubes. And also knowing that sometimes some supplies just may not be offered by a home infusion company. So, and that includes the feed and flush option. There are some companies that just don't offer it because it creates an expense that is unsustainable. And then obviously in home care, rule number one, we need to make sure our stuff fits their stuff, right? And that has to go along with this ENFit versus legacy connector. So we're having to navigate that. Feeding schedule. So that's the next thing I want to talk about. This plays into quality of life for our patients at home. So in the hospital, there's 24-hour nursing. We can do Q2-hour, Q3-hour feeding and flushing regimens, around-the-clock feeds on pumps, very common, not something that we really ever think about or question. But when a patient comes home, we really want to think about what can we do to that feeding regimen to make it more user-friendly, make it more achievable, avoid keeping them up all night long, Q3 hours to get up and do flushes, because there are some patients that are so compliant, they're going to follow that prescription to a T because they're terrified. But then it gets into their ability to rest and recover. And I'm talking about the caregivers or the patient, but rest and recover and actually take care of those patients, and really gets in the way of their experience at home on tube feeding. So our goal is to make it clinically appropriate, but also achievable in a quality of life sort of way. So we want to make measurements easy, right? None of the like very specific 225 milliliters of formula or water. It's not a really convenient way to prescribe for the home setting because it makes it difficult to manage. So these are the types of things that I want you thinking about as you're preparing your patient to go home. Okay, so pump type, it's going to look different, right? So this is part of setting expectations, right? Letting your patient know that the pump that you receive at home is going to look different than our hospital pump. It's going to be lighter weight. It's going to be portable. It probably will go into a backpack. You're probably not going to see this feed and flush option in the home setting. And then this comes up every so often out of our NICU discharges, is asking for syringe pumps. So that's not something that we use in the home setting because the expense is so significant for us. So we navigate the tiny little infusions with our home care pump options that we already have. Okay, so now let's talk about the feeding system. And when I talk about a feeding system, I'm talking about open system versus closed system. So in the hospital, we're very much used to this spike set and closed container. So whether it's a bag or a bottle of formula that's pre-filled, usually comes in 1 liter or 1.5 liters volume. And then you spike that and load the set and set that pump, and it can run for hours and hours and hours, right? So it's a really nice, clean, closed way to run a pump in the hospital setting, but does not usually make sense for our patients at home. So again, preparing the patient with appropriate expectations. Your pump is going to look different. Your formula is going to come packaged a little bit differently, either in pouches or in cartons. They're going to come in these different sizes. And this open system, when they're on a feeding pump, is, this is an explanation I've had to give many times over the years, but it makes it more home care friendly for the patient. We don't worry about the closed system, cross-contamination, infection risk. It's not an issue in the home setting like it is in the hospital. And we have to consider patients' ability to be successful in pouring in exactly what's needed for a set amount of time and being able to control the time in which they're going to refill or change out a feeding bag is really, really important for our patients. So that's why Open System allows for that control and that control over their lifestyle and timing of things. So that's one of the primary reasons why we use Open System for pump feeds at home. And it also allows us in home care, we have different protocols than we do in the hospital in terms of how long hang times are. So decanted formulas can hang for 12 hours as opposed to most hospital protocols, which are 8 hours. So it makes the math really easy for our patients that way. And this is all part of the education as we're preparing them to go home. So I'm going to call it a case study. It's sort of a case study, but it's really just a way for me to provoke you to think differently. Okay, so we're going to walk through this example, and I want you to think about, and I'm going to ask you some questions about how to think differently about the hospital feeding regimen and how you can have it change to be more home care friendly. So here's our typical hospital acute care prescription. In this case, we have a 1-cal diabetic formula. It's running at 90 milliliters an hour, almost continuously around the clock, and there's Q2-hour water flushes happening. This is a Medicare patient, and that doesn't usually matter in the hospital, but as a patient comes home, it starts to matter. The patient's fed gastrically, and the patient's been on this formula since they were in the ICU with high blood sugars because of steroid use. They were in pain, they had an infection going. So all of these things were playing into the choice for that diabetic formula. So here you are in the hospital, sort of assembling your home care plan, right? They're still in the hospital, so you're navigating their inpatient regimen, but you're beginning to assemble a menu of options for when they go home, because what we all know is that the physicians and prescribers who are writing the orders are basically taking your recommendations, and I'm speaking to the dietitians here, taking those recommendations and copying and pasting them into an order set. So when you prepare your prescribers with a home care plan during the inpatient stay, it helps everybody, okay? So we talked about our Medicare patient, diabetic formula, continuous pump feeding. I'm going to ask you a question like, what would stop your patient from tolerating gravity or bolus feeding? Is that pump actually needed? Especially when we're talking about Medicare, because Medicare will only pay for that pump if in fact there is a clinical need for it. Then I would ask you, what would stop your patient from tolerating a standard formula? Why do they need a specialty, what we call a specialty formula, or a higher level formula like a diabetic formula that requires us to justify its use and show evidence that it's clinically indicated? So what would stop your patient from tolerating that standard formula in a gravity or bolus feeding? And then also preparing them to understand that manual flush is the standard of care. What would stop your gravity or your gastrically fed patient from tolerating a manual flush? And then if that pump is in fact indicated, which it is a lot of times, have you outlined a home care plan to decrease the duration of those feeds, meaning a plan over, say, the next week or so to titrate to higher rates and fewer hours? So going from a 22-hour feed to an 18-hour feed to a 16-hour or 12-hour feeding in order to make it more home care friendly for that patient's lifestyle. And then lastly, if they're on a 1-cal formula, can you consider a transition to a 1.2 or perhaps a 1.5 formulation? Because that changes a lot of things, including how much that they have to infuse and how long they have to infuse. So here's my little, hospital compared to home care regimen side-by-side comparison, and what are the ways in which that makes a difference for a patient. So your hospital regimen, we're familiar with. If you're to translate that to cartons per day, that's 8 cartons per day of formula in an open system, and that would be, I have to get my calculator out. So 8 cartons per day times 30 days is 240 cartons a month. And if I divide that by a case, that patient's going to be receiving 10 cases every single month of formula. That's a lot to manage, lifting in, bringing in the door, right? We don't think about these things when we're in the hospital, but we do at home because we hear about it from them. So an alternative home care regimen that they could succeed on is a 1.5 option, similar calorie provision. We're going to bolus feed instead of pump feed. And we can spread those 5 cartons a day throughout the day. Honestly, you know, if a patient's tolerating things and they don't need specific precision, I'm going to let them know they can squeeze it in however they want. They could do 2 cartons at breakfast, 2 cartons at lunch, 1 at dinner. They could do 1.5 several times a day. It just depends. Like, honestly, I will give them that freedom as they get stable at home to design it as it works best for them. And using 5 cartons a day is 150 cartons per month. And if I divide that into my cases, that's 6 cases, just over 6 cases a month of formula instead of 10. So that has an impact on a lot of things, not just how much they have to feed through their feeding tube. Okay, so we've done our side-by-side comparison. I've walked you through the things that I want you thinking about, hospital versus home care. So now I want to cover briefly, what are the elements of a successful pre-discharge education or soon after getting home education on how to successfully feed at home. Our goal when we discharge patients home is we want them to stay home, right? So our goal is to discharge them home and then have them prevent readmissions. So with compliance, with hydration, with proper tube site care, all of the things. So these are the things that we need to cover in our education to ensure and promote better outcomes for these patients. And if they, have a readmission, have it be unrelated to the tube feeding, because our tube-fed patients get readmitted often, but if we can eliminate readmissions that are actually specifically related to the tube feeding, that's a win for us. So making sure they understand the prescription, how to administer with their method of administration, how to properly flush. We flush for 2 reasons. We flush for hydration, and we flush to keep that tube, the inner lining of that tube, clean. And then formula preparation, if they're having a mixed infant formula, making sure they know how to do that. Infection control basics to make sure that they're washing their hands the same way we do before we prepare dinner. And then making sure that they know how to take care of that feeding tube. It's their lifeline. And then also the tube site, because if their tube site is having problems, then that's also going to impact their quality of life. Okay, so now let's go into insurance coverage for home enteral nutrition. This was we got a lot of questions ahead of time before the presentation. Insurance is sort of a blind spot for a lot of people. And so your best partner in this journey in preparing your patient for discharge is your home care company, because commercial insurance and Medicaid and Medicare all have sort of specific guidelines, right? So commercial insurance, we need to verify that the patient actually has active coverage and what that coverage looks like, what their share of costs looks like. And sometimes we have to request authorization. Most of the time we have to request authorization from that insurance and submit documentation to show the need. And in Medicaid, sometimes we have to consider formularies. There are certain state Medicaid, traditional Medicaid programs that have specific approved formulas. And so that varies state by state. And then as it relates to Medicare, you have to meet their guidelines for coverage. So Medicare is a different animal because we don't request authorization from Medicare. We have to know going in what the guidelines are and bill appropriately and advise the patient whether or not they have active coverage. So the Medicare coverage criteria for enteral nutrition really hasn't changed much. There's been some modification to the LCD, and that was republished in the fall, if I'm not mistaken. And what has really changed with that is really more about formula justification and length of need. But let's talk about the primary criteria for coverage, and that is that the patient needs to have an enteral access device. Medicare Part B coverage for tube feeding is tucked under the prosthetic device benefit. And so a patient has to have a feeding tube in order for Medicare to pay for enteral nutrition. And that is the reason why oral nutrition supplements are not covered, right? It has to do with the way that the benefit is designed. And the same is true for TPN. It's tucked under the prosthetic device benefit. The patient needs to be receiving sufficient nutrients to maintain weight and strength commensurate with overall health status. So basically what that means is that it needs to be the life-sustaining portion of their nutrition intake. Would your patient fail without tube feeding if they were eating a little bit as well? So some people think that you have to be NPO or have no oral intake at all for Medicare to pay for their tube feeding, and that is not in fact the case. It has to be the life-sustaining portion of their nutrition intake, and without the tube feeding, they would actually fail, meaning lose weight, decrease their nutrition status, etc. And then the patient has to have a permanent impairment. So there needs to be a reason why a patient can't get food from point A to point B. So from the mouth to the stomach or from the mouth to the intestine. So that's either going to be a mechanical issue with swallowing, or it's going to be an absorption issue in the GI tract. The only thing that has changed with the recent publication of the LCD is that the length of need and this permanence is not articulated anywhere. So the best advice I can give you around this test of permanence is that the medical record needs to support a long-term need. And that is as specific as they have been with us as it relates to permanence. No longer can we just write 3 months or more and assume it's covered. That's not how it works. The record needs to support the need, and this is a compilation of the clinical evidence. It's the way I look at it like a court case, right? And I'm collecting evidence to support the need. And Medicare will ask for these things from a home care company if they believe that the patient does not meet the Medicare guidelines or if they choose to audit us. So we assemble clinical notes to show, yes, we need to show that the tube is placed. So tube placement reports are helpful. Notes from a dietitian talking about how much of their nutrition is coming from the tube feeding compared to what their assessed needs are. Speech therapy notes that talk about any impairment in swallowing, any clinical notes, progress notes from prescribers, nurses in clinics. So whether it's an ALS clinic or oncology clinic, just showing any evidence that supports the need for tube feeding is really what we're assembling to paint the picture of that it is reasonable and necessary. And that's Medicare language, that the tube feeding is reasonable and necessary. So to sum up this portion of the presentation, these are the things that really put together and feed into a successful experience at home for patients on tube feeding. We need proactive identification of potential barriers to compliance, right? We talked about what that could look like. Implement home care friendly strategies to make it more home care friendly for our patients and their caregivers. Have the support of clinicians in their tribe, in that patient's journey on tube feeding. They need experts surrounding them. So whether they're in clinic or they're with a home care company or they see a dietitian in the community, having an expert to help support them and navigate the ongoing experience is key to their success, because all of these things put together really help with the insight on that home environment and what the patient's lifestyle needs are. So in the last couple of minutes here, I want to cover enteral misconnection and get you up to speed on ENFit. So we all know what enteral misconnections are. Let's do a quick survey and see where your organization is at in relation to a conversion to ENFit. So are you already converted? Are you actively planning a conversion? Is your conversion currently underway, or do you have no plans to convert? And I lost my visibility to the results.
Cynthia, I can share some of the results that we're seeing here. So it looks like the majority, and this is fantastic, 36% have already converted. So that's awesome. There are 29%, however, that do not have any plans to convert. Okay. Followed by 22% where the conversion to ENFit is underway. And then remaining 12% are actively planning a conversion.
Great. Thank you so much, Yvette, for sharing that with me.
Sure.
All right. Well, that's super helpful because we're going to talk about why you need to be talking about it. Okay. So we understand the complexity of all the connections in the acute care setting. I think most people are familiar with the ISO standard. This is a global standard, 80369-3, to help prevent misconnection of small bore connector tubes with each other. So keeping enteral only to connect with enteral is really key in that. And so here's our language again. So we're talking about legacy connection. So this is the transition connector, which is currently in play and is being removed from the pump feeding sets. This is your legacy tube. This is your ISO compliant, or ENFIT, which is a trade name. It's a trade name for that global standard so that it is only connected to enteral devices. So that's what you're looking at there. And this is what it looks like in real life. So here's your legacy cath tip or catheter tip syringe plugged into a feeding tube. This is the med port with a medication syringe, and this is what it looks like with an ENFIT connection for flushing or feeding, and then the ENFIT connection with in the med port. And this is what it looks like in real life. Again, this is a patient who is pump fed. This is a J tube. This is a button. Here's her extension set. And then this is a close-up of that connection of that extension set, so where it sort of twists together. And these feeding bags, so this is one of the companies that manufactures home care pumps, and they have stopped production of feeding bags that have the white transition connector. So these bags are going to make their way through the supply chain, and you're going to start seeing ENFIT only connections on the end of that feeding bag sometime in the next 4 to 6 to 8 weeks if you haven't already. And then this is what her tube looks like. This is her gastric tube. So she has 2 stomas and 2 separate tubes. She has a dangler style tube in her stomach, and this has a drainage bag attached. So you can see how this ENFIT drainage bag connects to the ENFIT gastric tube for drainage. And this is a beautiful thing for her, is because it doesn't accidentally pop out. It's a more secure connection, and she doesn't get gastric fluids all over her lap or in her backpack inadvertently. And then this just shows what that flushing looks like, because she does flush her gastric tube even though she only uses it for drainage. This is an important reference that shows the timeline of all the GEDSA manufacturer members, and it talks about the 2 pump manufacturers and their timeline. So one has already stopped production, the other is about to, I think, at the end of the month. And then these are my best practices and lessons learned that I want to pass along to you. You need supply alternatives. You need to collaborate with manufacturers, with hospital clinicians, with distributors. You have to understand the patient satisfaction component of it. It's a global safety standard, but there's actually wins for the patient in terms of, their experience on tube feeding at home. And then lastly, proactive education is key for our patients that are converting over to ENFIT. So in conclusion, as we wrap up and move towards our Q&A session, I want you to know that the home enteral nutrition regimen can and should look different than what you're doing in the hospital, and to prepare the patient for that difference. The coverage for home enteral nutrition is often dependent on that evidence and that adequate documentation of necessity, so keep that in mind. And then lastly, we need to make sure that we understand the connections, and knowledge of ENFIT at this point is imperative, and it sounds like we're continuing to move the needle on that. So with that, I will show our references for your use, and then we'll go into our Q&A session. And at this point, I think, Yvette, I'm going to toss it back to you.
Wonderful. Well, thank you so much, Cynthia. Great presentation. A lot of really good practical information that clinicians can use, whether you're in the inpatient setting and supporting your tube-fed patients as they're going to be discharged, or if you're in that home care setting and you're going to be receiving these patients, and to individualize their nutrition management, so that, to your point, we want to make sure as clinicians that they have the best guidance and nutrition therapy that they can for the best quality of life, and just to have as regular of a routine at home, whatever that may be, because you could have pediatrics, you have adults, you have those that are working, those that may not be working. So a lot of differences between what those patient needs are. So thank you for sharing that. And in the midst of everything, post-COVID, or in the midst of this COVID, we're trying to follow the recommendations. The FDA strongly encourages everyone to convert to ENFit, because at the end of the day, we're here to support patient safety. So this is a continuing process, and happy to see that I think it was 29% have already converted to ENFit. So hopefully the information shared today for that other 30% that are not planning maybe gives you some additional thoughts for why aren't you, or maybe if there haven't been discussions, it's definitely time to have those discussions and find the right people. So I'm seeing the questions as they're pouring in. I'll categorize some of these questions that are coming in. Just to clarify, you had mentioned when it comes to ENFit, and again, a push for patient safety and the ENFit connection system. You mentioned that there are some manufacturers that will no longer be providing these transition connectors. And so if the home care is receiving patients and they don't have it, and the hospital has placed an ENFit tube, what should they be doing so that, because if they don't have a connector and they have a patient with an ENFit feeding tube, are they going to be able to flush that tube and feed that tube, or are they going to be in a dire situation?
Yeah, so it will be nothing new to really assess to make sure that our supplies, our home care supplies, connect with the hospital patient supply. So that initial assessment, eyes on, nutrition focused physical exam to make sure, okay, what kind of tube does my patient have? If they've got ENFit tubes, they're good, and they're pump feeding, they're good to go, because the pump sets have been ENFit for many years. What's changing is that transition connector is going away in terms of being packaged with the feeding set. So there will be transition connectors available for a period of time as a separate purchase. So if you are working in a hospital that has not made any plans around ENFit, is not underway, I see we've got 29% with no plan. So there's a third of our attendees here that need to, if they're working in a hospital, really get to know who is making those decisions and make sure they have a plan to have a transition connector for those feeding bags, or to start placing ENFit tubes in their patients. And then patients that go home with, and like I said, if they go home with an ENFit tube, the key to their success is going to be making sure they get ENFit syringes to go home with. So if for flushing, and if they're bolus or gravity feeding, again, they're already, if they're bolus feeding, they need the ENFit syringe to connect and flush. But if they're gravity feeding or they're pump feeding, the bags are already prepared for them to connect.
Wonderful, thank you. There's a question that came in, we're talking about bolus feeding, and someone's asking here, Michelle's asking, what is the largest volume that you would bolus for a gastric feeding tube in an adult patient? And how quickly would you gravity feed a carton? So, a 240 ml-ish carton to that patient.
Mm-hmm. Yeah, I take a really practical approach to this in educating my patients. So when they're brand new coming home, I really like to have them take it slow and easy. So if they're syringe feeding, using a syringe of formula, wait 5 minutes, do another syringe of formula, wait 5 minutes, right? And spread it out over the course of 20 or 30 minutes. So the same time it would take them to sip on a carton of formula. So mimic what they would normally do if they were drinking it in terms of time frame. In terms of volume, it really depends on your patient. So I have had some patients who can tolerate upwards of 2 cartons of formula at a time, but the key is how fast are they bolus feeding? Because my power feeders who draw up formula and push it through really quick, or connect that syringe and let it drain through really quick, because they really don't have time for this watering and feeding. Like, they really just want to get it over with, and they can overdo it sometimes. So they really need to respect their reservoir, respect their tolerance, and sort of slow things down. I could talk for hours of the negotiations I've had with patients to very common sense tolerance complaints, where I have to go back to this idea of you're feeding too fast. So before you jump to a formula intolerance assumption, verify that your patient's not feeding too fast, because when they go home, all bets are off, especially after they've been home for a while, or if they've done this before and they just, know how to do it and they just used to tolerate it. I've had that where they tolerated very quick feedings with large volumes in a 5-minute period of time, but now all of a sudden it doesn't work anymore for them. So it's just a matter of educating to respect your reservoir, which is your stomach, and slow it down. So my comfort level for a brand new patient at home bolus feeding is a 20-minute minimum per carton to kind of take it easy and ease in, and then they can gradually increase the speed that way.
Very, very helpful. Thank you for sharing that, your expertise with that. There's another question that came in. There's several questions around blenderized tube feeding. I know that that's quite a popular type of formula that's requested either by the parents and or the patients themselves. In regards to insurance, though, the question is, if it's a Medicare patient, and I'm going to assume it's referring to the local determination code that changed in, I believe it was this past fall, September-ish, November-ish timeframe. Do you have to justify or show that a patient failed on a different formula or a standard formula before you can try them on a blenderized or commercially blenderized tube feeding formula?
So that's a really good question, okay? Because what changed in the latest publication of the guidelines and in the policy article is they removed this language around trial and failure. So this trial and failure language no longer exists, but what remains, so there's not a significant change in terms of this need to be able to justify the need. So specialty formulas or higher level formulas, so your B4149s, your blended formulation, you need to show evidence that it's reasonable and necessary. You don't have to have a trial and failure. It helps if you do. It's a good practice to try somebody on a standard formula first before jumping straight to a blend, but you need to show and document what the intolerance is to the standard formula. You need to show evidence that it's reasonable and necessary, and that's as much guidance as they've given.
Okay, thank you for that. I realize that we're at the hour, and
probably
there's
not
so
what
many
you were looking for.
questions. Yeah, well, unfortunately, but it sounds like the recurring theme that I hear is document and substantiate why. You're the clinician, you're the expert, so you know what's best for your patient. So document the why behind the recommendation, so it's supported if there's any questions about what's being recommended.
Exactly right. Exactly right.
Wonderful. Well, oh goodness, you know what? I want to be respectful of everybody's time. Let me ask you one other, if you could respond fairly quickly, maybe just to show a couple of tips or what your experience is. So there's several questions worded a little bit differently from clinicians that are either practicing, a lot of them are practicing in inpatient in the hospital, and they just want to know what's, like a couple, 2, 3 key things that they can do to help with the successful transition of a patient from the hospital to the home care. Is it, for example, would it be working closely with discharge planners if they have one, writing notes, or how do they communicate so that what their recommendations are are received over to the home care? And then obviously any clinical parameters or anything that you would recommend that you would want to follow once they're in the home care setting?
Yeah, thank you for asking that question and for wanting to help. So the best thing you can do is put in your progress notes if you're working inpatient, whether you're a nurse, dietitian, inpatient notes, your menu of options, your home care plan that you would like to see for your patient. That will make its way into a prescription, and it makes its way to the home care clinician who is picking up the ball, so to speak, to help that patient at home. So putting in and going back through what I just, those 10 slides, this, hospital version versus the home care version, and really looking at how can I do this differently for my patient at home so that it's simpler, easier, more affordable, more achievable, and documenting that in your note for a home care plan, and then connecting with your case managers to let them, making sure that that is included in the documents that make their way to the prescriber, to the home care company that's going to be providing their formulas, and to allow the home care company to explore the insurance options, coverage ability, because it's one Blue Cross patient in bed A compared to a Blue Cross patient in bed B could have completely different coverage. It's very plan specific. And then sometimes we navigate the clinical plan backwards from what the insurance coverage looks like. If you walk away knowing nothing else, just because a patient's insurance doesn't cover tube feeding doesn't mean they don't need it. And so we're going to do everything that we can to make it achievable for them at home if they have limited coverage or a larger share of cost or perhaps no coverage. But most of the time, insurance is going to cover most of the tube feeding. So just documenting the menu of options in a home care friendly way is the short answer.
Thank you so much, Cynthia. And I want to thank everybody in our audience. We absolutely appreciate your participation. And on behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice and enjoy the rest of your day.